Hello, my name is Nicholas Herrman. I am a fourth-year emergency medicine resident at the University of Michigan, and I'll be talking to you about my project entitled Initial Data Evaluating the Effects of Implementation of a Femoral Nerve Block Guideline for Hip Fractures in a Community Emergency Department. I have nothing to disclose for this presentation. First, a little bit of background. As we're all aware, hip fractures are common. They're especially common in older patients as well as in female patients. Pain with hip fractures can be difficult to control. Traditionally, we've relied on a lot of opioid pain medications, but as we are all well and increasingly aware, opioids have a large number of drawbacks, especially in the older population that typically suffers from hip fractures. In light of this, we have been trending towards non-opioid measures, and as part of this, we have been trending towards regional pain control with regional nerve blocks, including femoral nerve blocks. A number of studies have examined femoral nerve blocks, and they've shown benefit both with patient pain scores as well as total opioid usage during hospitalizations, and a couple of studies have also shown improvement in complications such as delirium, partly because opioids may be driving some of those complications. However, the majority of studies that have been done have been set in large academic tertiary care centers. We care for a lot of our hip fracture patients in community emergency departments and community hospitals, but the number of studies looking at hip fractures and pain control, especially with regional analgesia, has been limited with this regard. A little more background here. So this project was performed in a community emergency department, and this department about a year and a half ago implemented a femoral nerve block guideline for hip fractures. In brief, patients presenting above the age of 60 with hip fracture were eligible for a femoral nerve block as long as they met a certain number of inclusion and exclusion criteria. Exclusion criteria included no supratherapeutic anticoagulation, though therapeutic anticoagulation was completely fine, as well as no hypersensitivity to local anesthetics. In addition, the affected extremity in patients had to be neurovascularly intact. So our objectives for this study were, first of all, does implementing this guideline increase performance of femoral nerve blocks in the emergency department? That is to say, are we performing more femoral nerve blocks in the emergency department after implementing this guideline? In addition, do our blocks affect opioid use? Can we limit total opioid use in patients with hip fracture who underwent femoral nerve block? And do the blocks affect other patient measures, and in particular, do they affect hospitalization complications, namely pneumonia, urinary tract infection, and delirium? This study was designed as a before-after retrospective chart review. It had full institutional review board approval at our institution. And we examined 6 months of data prior to femoral nerve block guideline implementation for hip fractures, as well as 6 months of data after guideline implementation. And we allowed for a 2-month washout period immediately following guideline implementation. And as we discussed, patients who were included had to meet institutional inclusion and exclusion criteria for femoral nerve blocks for hip fractures at our institution. In terms of our results, we looked at a total of 121 patients. 39 were from the period before guideline implementation, and 82 were from the period after guideline implementation. And looking purely at policy adherence, i.e., how many patients actually received femoral nerve block who were eligible for this in terms of hip fracture, before the guideline was implemented, only 2 of the 39 patients underwent femoral nerve block, for about 5%. After guideline implementation and after the 2-month washout period, 44 patients out of 82, which was 53%, which by our statistical analysis was statistically significant. What about our other results? In terms of morphine equivalence, what we did was look at parenteral morphine equivalence as calculated by standard equivalency, and we looked at all opioid use up to time to operating room. We did not look at opioid use after operative intervention, as we felt that the femoral nerve block is designed to be time-limited intervention and would unlikely to show any effects after going to the operating room. Unfortunately, what we found was that patients who did not receive a femoral nerve block used a median of 8 milligrams of morphine over this time period, and those who did have a block used 10 milligrams of morphine, which was not a statistically significant difference. In addition, both hospital length of stay as well as time to operative intervention were very similar without statistical significance. When looking at the number of complications that we had discussed, with delirium, pneumonia, and urinary tract infections, as well as for any one of those complications, there was also no statistical difference between patients who underwent femoral nerve block and patients who did not undergo femoral nerve block. So in conclusion, an institutional femoral nerve block guideline for hip fracture did increase block performance in the emergency department significantly. However, we found no difference in terms of total opioid use prior to operative intervention for the hip fracture, nor did we find any difference in hospital length of stay, time to operative intervention, or the complications that we discussed. This study does have several limitations. We had a rather limited sample size with only 121 patients, as we only examined 6 months of data prior to the guideline implementation and 6 months of data after the guideline implementation. In addition, we only examined opioid use prior to the patients going to the OR instead of opioid use during their entire hospitalization. Furthermore, we had a limited number of variables analyzed, especially with regard to complications, and we did not incorporate any sort of pain scoring, which other studies have done. In terms of future directions, we have a couple of goals. We are actively working on a study very similar to this, but with an expanded sample size, going back a year before guideline implementation as well as a year after guideline implementation, which we believe will significantly increase our sample size. We also have plans of looking at other outcomes, including pain scores, to see if femoral nerve block may affect any of those other variables of interest. With that, I appreciate your time. My email address is below, should you wish to contact me. Thank you.